It's an honor to be invited to contribute to today's deliberations on the Tobacco Products and Electronic Delivery System Control Bill for South African people. I've been in South Africa many times. I really enjoy your country. I love it so much. I joined you today representing the Center of Excellence for Harm Reduction at the University of Catania in Italy. It is in Italy. Actually, it is in Sicily. So we share the same good weather. And we will do that with a focus on harm reduction research because that's our excellence and our skills. In my remarks, I will aim to provide evidence-based insights regarding the potential health implications of harm reduction strategies while aligning with the broader objectives of protecting public health in South Africa and supporting informed policy making for your government. Let me allow to share my slides. I took the liberty to shorten the discussion because I've seen that you had so much discussion before, and so I'll make it shorter. Of course, we all know that that the smoking problem is global, and you have, like in Italy, a very high prevalence of smoking. It is interesting to note that your smoking prevalence it equates the one that we have in Italy, in particular in Sicily, where I reside. I would like to try and provide evidence on three major themes. The first one will address the impact of tobacco harm reduction tools, in this specific case, electronic cigarettes and smoking cessation. Triangulation of systematic reviews and real-world evidence shows that e-cigarettes help smokers quit. And this is the evidence. I mean, probably you know already that the Cochrane Library is the highest level of evidence, and their conclusion is that people are more likely to stop smoking using nicotine e-cigarettes than using nicotine replacement therapy, specifically patches and gums. So this is all about very rigorous randomized controlled trials, because that's what it does. The Cochrane Library is a systematic review pooling all the evidence. In this very latest release, they evaluated the 7 high-quality randomized controlled studies, and the conclusion is written here. So it is effective to help people quitting smoking more than standard medicinal products. However, as I was mentioning before, randomized controlled trials are not really representing the reality of the smokers and their daily life. So it is best also to triangulate the data from randomized controlled trials with real-world evidence data. And I've selected this one coming from the US. It's one of the largest surveys. It is called the National Health Interviews Survey. And you will see in this slide what is the trend line in the prevalence of smoking in the US for this population of nearly 1 million of respondents. And you will see the trend line tends somehow to be reduced. I mean, there's an accelerated decline in the reduction in smoking prevalence, whereas at the same time, at around the year 2006, 2008, there is an increase in vaping uptake amongst this population. This is to suggest that vaping is basically replacing smoking, And vaping is very well known to be much less harmful than smoking because of the lack of combustion. In the same study, the authors were very clever to do some sub evaluation in the younger population. And you will see for yourself that the smoking trend line and the decline in smoking prevalence accelerated in the US on the same time window. And this acceleration in smoking decline was paralleled by an uptake in vaping. This is to suggest clearly that the more vaping uptake, the more substitution of smoking. This has led basically in the US to near eradication of smoking among students in high schools and colleges. A second theme I would like to present to you is about health effects of electronic cigarettes. Of course, if you quit smoking, you will avoid exposure to more than 8,000 chemicals that are present in tobacco smoke and that they are responsible for smoking-related diseases. But quitting smoking is not an easy task. I've been leading smoking cessation centers for more than 25 years, and it's a frustrating job with a lot of relapses, even in highly motivated people. One solution of this problem is to, in those people who cannot or do not want to quit, to try and suggest them to try combustion-free nicotine-containing products. And of course, these products have been shown to have reduced emission, consequently reduced exposure, and it is very likely, given the toxicological profile, that this will lead to reduced harm. How can we evaluate the health improvement after switching? How can we substantiate this reduced harm in considering that epidemiology is not available there because these products have been introduced only in recent times? The approach can be multifaceted, so we can just look into in vitro cytotoxicity and mutagenicity studies, or we can just look into in silico science and recent epidemiological studies, or we can just evaluate clinical studies, looking specifically for health effects indicators of biomarkers of potential harm. Let's start with in vitro studies, just a couple of slides. Let me illustrate what I believe is the largest replication projects in tobacco harm reduction science. Why it is important to talk about replication? Because most of the studies that have been published in this space are not replicable. So in order to address this problem, the Center of Excellence has designed a study involving 5 different labs across the world. We use the same equipment, so same smoking machines, same vaping machines. We train the scientists and researchers in these 5 sites, one in Indonesia, one in Serbia, one in Oman, one in the US, and one in Italy, to perform the same standardized procedures. And if you look at the panel on the right-hand side of the slide, you will see for yourself these dots just represents the different sites. And you will see that there is some variability. As I mentioned before, replication is problematic when we carry out the studies like this, even under the most stringent standardized conditions. But overall, if you consider 100% the baseline, meaning viable cells, anything below 100% is dead cells. And you will see that by smoking cigarettes, you are going to kill about 75% of the cells in these petri dishes. When you use tobacco harm reduction tools, there is very little effect. In some cases, the cells are actually growing. They're growing because in the petri dishes, in this culture, there are growth factors, and probably the effect of these vapors, of these aerosols, are not sufficient enough to cause cytotoxicity. In summary, these products are about 80% less toxic than tobacco cigarettes, and our findings are aligning with what has been shown by several researchers all around the world. Another important aspect that I would like to emphasize is these replication projects are also showing that electronic cigarettes are about 99% less genotoxic compared to tobacco combustible cigarettes. Another approach is to look at the epidemiology and in silico science. Of course, as I said before, we don't have enough, there's not enough time because electronic cigarettes have been introduced very recently. The epidemiology to show risk, disease risk, will not be enough. But there is a proof of concept idea that comes from Sweden. In that country, snus is an oral nicotine product that doesn't cause combustion, and there is a long-term snus use in Sweden, dating back the 60s and the 70s. And you see from this slide that Sweden has the lowest lung cancer mortality compared to all the other European countries, considering that in EU snus is banned. So they cannot use snus at all, whereas Sweden, because of a specific provision in their law, they can use snus, and they have the lowest lung cancer mortality in Europe, and they have also the lowest cardiovascular disease prevalence in Europe. There are also other approaches to test this evidence using in silico studies. For example, using lean systematic reviews. Systematic review process basically screens high quality studies and then provides a summary out of the best quality studies that have been published. In this specific case, we conclude that smokers who choose to switch to electronic cigarette do not have additional cardiovascular risk, and they can benefit from this choice. In another similar systematic review study, we show that smokers who choose to switch to electronic cigarette do not have additional respiratory risk and can benefit from this choice. Another approach to substantiate health improvements after switching to tobacco harm reduction tools is clinical research. in my experience, I've learned a lot by observing people coming to smoking cessation clinics. And one of the first things that I learned from my patients was that just 48 to 72 hours after quitting smoking, these people were already enjoying the capacity of getting the taste of food again, smelling, smelling it was back again. And this is probably simply because uh, there is a reversal component in the sensorial tract of the nose and of the mouth. Using this idea, we implemented a saccharin test. In short, a saccharin test is introducing a saccharin tablet in the nostril, as you can see here, and then you ask the patient to keep swallowing for continuously for until she or he perceive the sweetness in the back of the throat. The timing from the insertion of the tablet, of the saccharin tablet, until the subject can perceive the sweetness in the back of the throat is called mucociliary clearance transit time. The mucociliary clearance transit time can be prolonged in smokers, particularly prolonged in smokers, and the reason is because the cilia of the upper airways are completely damaged, as you can see here. Here in the electronic microscopy slide, you can see complete desertification of the cilia compared to non-smokers. So it is clear that if the cilia are not operating very well, it will be impossible to transfer the sweetness of a saccharin tablet in the back of the throat. And you will see here what happened when we compare current smokers here with never smokers. Current smokers, of course, have a very prolonged saccharin test transit time. It's more than 11 minutes. In this particular experiment, in this particular study, was about 14 minutes. And never smokers, on the contrary, have a very a shorter saccharin test transit times. In this particular study was about 7 minutes. And interestingly, the 7 reduced saccharin test transit time is similar to that of former smokers, indicating, as I was learning from my own patients in the smoking cessation clinic, that this effect is totally reversible. Here you see what happens in people who completely stop smoking by switching to electronic cigarette or heated tobacco products. You can see the level of saccharin test transit times equates that of never smoker and former smokers. Another thing that I noticed in people quitting smoking in smoking cessation clinics, and they quickly refer an increased level of exercise tolerance. So
hello,
I thought,
Professor.
yeah,
Professor,
yeah.
you are left with 7 minutes and you are nowhere halfway with your slides. We did not give you an hour. I see you've got
Thank you,
50.
thank you. I will make the end of the presentation is going to be relevant, so don't worry. I will make it quick. Thank you, Honorable President. We use excellent exercise tolerance to measure anaerobic capacity, which is VO2 max. And this is just an example in one of our studies showing that smokers, the blue bar, have a reduced anaerobic capacity compared to former smokers and never smokers, represented here in red and green. Interestingly, in a in a prospective study of people who are switching to electronic cigarette, there is an improvement already at 4 weeks when you quit smoking by switching. And this improvement is maintained at week 12. So these people perform much better in terms of physical performance. In terms of smoking in patients means that people can walk up more stairs or can do more things in their daily life. Another important aspect that can be evaluated in simple terms is the improvement in respiratory symptoms. Here you see improvements expressed as this is a respiratory symptoms scores. And in smokers, of course, the scores are higher because they have more respiratory symptoms. But in former smokers who quit by switching, this level is substantially reduced. And these are more evident from other studies. I will switch to something else. We've been talking about healthy smokers, but what about people who have already developed a smoking-related disease, such as in chronic obstructive pulmonary disease, such as COPD? This is perhaps one of the first evidence published in 2014 of a global survey in which 1,062 people with COPD stated that their respiratory symptoms improved in 85% of these subjects after switching to electronic cigarettes. We wanted to test this survey in a clinical setting. So we follow up for up to 5 years COPD smokers who opted to use electronic cigarettes. So we single out these people and we follow them up for 5 years. And we noticed a marked reduction in cigarette consumption, significant improvement in lung function and quality of life, and less, and this is important, less respiratory exacerbation, which is a very common cause for hospitalization of people with COPD. These are the details of the study. You will see that already at 12 months, people were massively reducing cigarette consumption. Of course, if you massively reduce cigarette consumption, you end up having a progressive improvement in lung function, whereas the control were progressively having a progressively decline in lung function. In parallel, people who quit by switching have a large improvement in quality of life, whereas control were staying stable. This is the impact on respiratory exacerbation, 40% less respiratory exacerbation in people switching to electronic cigarette in this case. And the final theme is absolute health effects of e-cigarettes. Of course, it's very difficult to understand health effect of e-cigarettes in people who previously smoked. So the only way to evaluate the absolute health effects is to study people who vape but who have never smoked in their life. We were fortunate enough to have a small cohort of these subjects, and in a 3.5-year study follow-up, we were able to show that these people had no long-term health concerns. I'm not going to go into the details, but if you want to have more details, I can provide them. This is a much larger study. It's a global study called the Veritas Cohort. In these studies, we are again focusing on vapers who never smoke in their life. And we used again this respiratory symptom experience scale questionnaire to evaluate level of respiratory symptoms. Never having symptoms is expressed as 1. Everyday symptoms is expressed as a 5. So this this scale ranges from 1 to 5. And these are the results that we see in this population. Vapors had a 1.61 in terms of frequency of respiratory symptoms compared to control. Control were never vapors, never smokers. So basically there's no difference up to 3.5 years. And I will skip to that. And this is take-home message. Prevalence of smoking remains too high. Current tobacco control policies alone are not enough. Switching to tobacco harm reduction tools may help people abstaining from smoking. Combustion-free products are unlikely to raise significant health concerns under normal condition of use. This is very important, under normal condition of use. And people using or intending to use this product should receive correct information about their risk and their benefit. Honorable Chairperson, honorable members, I thank you for attention and I welcome any question or comments you may have.